You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about post-heart transplant. We'll talk about immunosuppression and mechanisms of immunosuppression. Then we'll talk about rejection, including hyperacute rejection, acute cellular rejection, antibody-mediated rejection, and chronic rejection. We'll focus on CAV, chronic allograft vasculopathy. Then we'll talk about malignancy, infection, and some pearls about physiology. Let's start with immunosuppression. There are three phases of immunosuppression: induction, maintenance, and treatment of rejection. Induction therapy refers to the high-intensity immunosuppression used immediately after the transplant and the first few days in a CT-ICU. Induction therapy consists of antibodies and very high doses of maintenance immunosuppressants. Maintenance therapy refers to immunosuppression used for the rest of the patient's life. The most common regimen for induction therapy is methylprednisolone plus basiliximab. The most common regimen for maintenance therapy is tacrolimus plus mycophenolate mofetil plus prednisone. Let's talk about mechanisms. We are trying to prevent rejection by interrupting the rejection pathway. What is the rejection pathway? Acute rejection begins when the T cells realize that donor antigens on antigen-presenting cells, or APCs, or donor APCs, are different from its own recipient antigens, or APCs. The T cell receptor, or TCR, engages the major histocompatibility complex, MHC, on the APC and waits for co-stimulatory signals between CD28 from the T cell and B7 from the antigen-presenting cell. When the co-stimulatory signal occurs, calcium-dependent activation of calcineurin occurs. Calcineurin dephosphorylates the transcription factors nuclear factor of activated T cells, NFAT, and activator protein 1, AP1, allowing them to enter the nucleus and bind to the promoter region of interleukin 2 and other cytokines. Interleukin 2 then goes to activate surface receptors such as interleukin 2 receptor to stimulate the clonal expansion of T cells, being T helper cells. Interleukin 2 and its accompanying cytokines produced by T helper cells also stimulate proliferation of other cells in the immune system. Furthermore, binding of IL-2 to IL-2 receptor also stimulates TOR, which regulates the translation of mRNAs to proteins that regulate the cell cycle. As the cell cycle progresses, de novo purine synthesis is needed to generate new DNA and RNA. So this process can be interrupted by calcineurin inhibitors such as tacrolimus or cyclosporin, antimetabolites such as mycophenolate mofetil or azathioprine, TOR inhibitors such as sirolimus or everolimus, corticosteroids such as prednisone or methylprednisolone, antithymocyte globulin and thymoglobulin, and monoclonal antibodies such as basiliximab or alemtuzumab. Since these are often referred to by their brand names, let me give you this information twice. Tacrolimus, which is Prograf, cyclosporin, which can be SAN-immune if it's oil-based, or Gengraf and Neural if microemulsion-based. These are calcineurin inhibitors. They prevent calcineurin from activating the nuclear factor of activated T cells and thus preventing transcription of interleukin 2 and other cytokines. So again, tacrolimus, which is Prograf, cyclosporin, which is SAN-immune or Gengraf, are calcineurin inhibitors. Next, mycophenolate mofetil, which is Cellcept, or mycophenolate sodium, which is Myfortic, or azathioprine, which is Imuran, are antimetabolites. They interfere with synthesis of nucleic acids, preventing proliferation of lymphocytes. So once again, mycophenolate mofetil, which is Cellcept, mycophenolate sodium, which is Myfortic, or azathioprine, which is Imuran, are antimetabolites. Then you have prednisone, which is Deltasone, prednisolone, or methylprednisolone, which is Medrol. These are steroids, and they alter interactions with proteins to decrease interleukin and TNF, tissue necrosis factor. Everolimus, which is Zortress, or sirolimus, which is Rapamune, are mTOR inhibitors. They block cell cycle progression at the G1 to S phase. These are the immunosuppressants to know about. Now let's talk about the actual management. Calcineurin inhibitor, as I mentioned, refers to tacrolimus or cyclosporin. In heart transplant, we mostly use tacrolimus. The 2023 heart transplant recipient guidelines from the ISHLT say calcineurin inhibitor-based therapy remains the standard immunosuppressive protocols used after heart transplant. That's a class 2A recommendation. Meanwhile, antimetabolite refers to mycophenolate or azathioprine. In heart transplant, we mostly use mycophenolate mofetil. The 2023 heart transplant recipient guidelines say mycophenolate mofetil, everolimus or sirolimus as tolerated, should be included in contemporary immunosuppressive regimens because therapies including these drugs have been shown to reduce onset and progression of CAV as assessed by IVUS, Class 2A. The results of 2 decades of trials have shaped the current thinking, which is as follows. For the default heart transplant recipient, you can give tacrolimus plus mycophenolate mofetil plus prednisone. That is what you will see most commonly. If side effects of tacrolimus occur that cannot be tolerated, such as seizures or encephalopathy, you can replace tacrolimus with cyclosporin. So your combination will then be cyclosporin plus mycophenolate mofetil plus prednisone. If you have high risk of CAV or CMV infection, then you can replace mycophenolate for sirolimus or everolimus. So your combo will then be tacrolimus plus sirolimus or everolimus plus prednisone. If you have cancer, you can replace the CNI with mTOR inhibitor such as sirolimus. So your combo will be sirolimus plus mycophenolate mofetil plus prednisone. Now, how about monitoring? Regarding monitoring of immunosuppressant levels, the 2023 heart transplant recipient guidelines say measurement of 12-hour trough concentration for twice daily tacrolimus and a 24-hour trough concentration for once daily tacrolimus is a recommended drug monitoring method for routine clinical use. The therapeutic range of tacrolimus levels varies depending on concomitant drugs, toxicity concerns, and time after heart transplant. In general, when used in conjunction with azathioprine or an mycophenolic acid preparation, tacrolimus trough concentration targets range between 10 to 15 nanograms per milliliter during the early post-operative period, days 0 to 60, between 8 to 12 nanograms per milliliter for the next 3 to 6 months, and between 5 and 10 nanograms per milliliter in stable patients 6 months after heart transplant. That's a Class 2A recommendation. We should also know the side effects of these medications since you're prescribing them. The main side effects of tacrolimus are tremors, paresthesias, nausea, diarrhea, vomiting, hyperuricemia, hypomagnesemia, and thrombocytopenia. The conditions that tacrolimus can worsen are hypertension, diabetes, hyperlipidemia, and renal insufficiency. These things can all progress with tacrolimus. Tacrolimus does not cause the hirsutism and gingival hyperplasia that cyclosporin does, even though they are both calcineurin inhibitors. Tacrolimus causes hyperglycemia and neurotoxicity more commonly than cyclosporin. The main side effects of mycophenolate mofetil are nausea, diarrhea, emesis, anemia, and neutropenia. Unlike mycophenolate mofetil, tacrolimus does not cause anemia or neutropenia commonly, although it can cause thrombocytopenia. Also be aware of interactions of calcineurin inhibitors with other drugs. Diltiazem and verapamil will increase the levels of calcineurin inhibitors, causing nephro and neurotoxicity, so decrease the dose of tacrolimus by 20 to 50%. Azole antifungals will increase the levels of calcineurin inhibitors, causing nephro and neurotoxicity, so decrease the dose of tacrolimus by about 33 to 50%. Phenytoin will decrease the calcineurin inhibitor level, causing rejection, so consider increasing the dose of tacrolimus by 50 to 100%. Calcineurin inhibitors increase the statin level, causing rhabdomyolysis, so try to use the lowest statin dose possible. Now that we've gone over the immunosuppression medications, we can talk about rejection itself. There's hyperacute rejection, acute cellular rejection, antibody-mediated rejection, and chronic rejection. The timing of hyperacute rejection is within minutes to hours after transplantation. It's mediated by pre-formed antibodies, usually against donor HLA antigens. Pre-existing antibodies lead to widespread complement activation and vascular thrombosis, causing immediate graft failure. The diagnosis is usually very quick and obvious because it manifests as immediate graft failure. Biopsy will show massive necrosis. This is usually irreversible and requires immediate retransplant or emergency plasmapheresis. Next, you have acute cellular rejection, or ACR. Acute cellular rejection typically occurs in the first 3 to 6 months, although it can happen at any time. The mechanism is T-cell mediated. Host T cells recognize foreign antigens on donor graft tissue, leading to an inflammatory response. T cells infiltrate the myocardium and initiate immune-mediated injury. Diagnosis: it is identified through endomyocardial biopsy and graded from 0R, which is none, to 3R, which is severe, based on ISHLT criteria. R means no rejection. R means mild rejection with mild perivascular or interstitial lymphocytic infiltrates. R means moderate rejection, that's more extensive infiltrates and myocyte damage. And 3R is severe rejection, diffuse infiltrates with extensive myocyte damage and possible hemodynamic compromise. Mild rejection may be treated with high-dose corticosteroids, while more severe rejection may require anti-thymocyte globulin or other immunosuppressive agents. Next, we have antibody-mediated rejection, AMR, also called humoral rejection. This can occur anytime, often early after transplantation. The mechanism of antibody-mediated rejection is B-cell mediated, is humoral, antibody production. Antibody-mediated rejection occurs when the immune system produces antibodies against the donor heart, usually anti-HLA antibodies, that causes damage to the endothelium of blood vessels, leading to capillary inflammation, graft dysfunction, and potential chronic rejection. Biopsy of antibody-mediated rejection will show capillary inflammation and deposition of complement. C4D staining is typically used. Presence of donor-specific antibodies, DSA, is often detected through serologic testing. It is treated with plasmapheresis, IVIG, rituximab, and/or bortezomib, depending on the severity of the antibody-mediated rejection and antibody levels. Then you can have chronic rejection, which is also called cardiac allograft vasculopathy, or CAV. This develops years after transplantation. The mechanism is chronic long-term immune-mediated injury that leads to progressive coronary disease of the graft. It causes diffuse concentric narrowing of the coronary arteries, leading to ischemia. Unlike typical atherosclerosis, CAV affects both the epicardial coronary arteries and the small intramyocardial vessels. It may present as silent ischemia due to denervation of the transplanted heart, and it needs to be detected via coronary angiography or intravascular ultrasound. You may also see signs of graft dysfunction on biopsy or echo. There is no cure to rejection from cardiac allograft vasculopathy. The treatment is aimed at preventing progression through optimal immunosuppression and managing traditional risk factors such as cholesterol control. In severe cases, CAV may require retransplantation. To recap, hyperacute rejection is antibody-mediated, occurs within minutes or hours, and is often fatal without immediate intervention. Acute cellular rejection, ACR, is T-cell mediated, occurring typically within the first 6 months, diagnosed by biopsy, and managed with corticosteroids or anti-thymocyte globulin. Antibody-mediated rejection, or AMR, involves B cells and donor-specific antibodies diagnosed via C4D staining and serologic tests, and treated with plasmapheresis and IVIG. Chronic rejection, CAV, is a long-term process leading to coronary artery disease of the graft, often diagnosed by coronary angiography and managed conservatively with risk factor control or retransplantation. Patients who do not experience acute rejection within the first 6 months after transplant have a lower incidence of late rejection. An endomyocardial biopsy should be performed as early as possible if there is suspicion of symptomatic acute heart allograft rejection. That's a class 1 recommendation. What do the guidelines say about management of acute cellular rejection? According to the ISHLT guidelines, high-dose intravenous corticosteroids should be first-line therapy for symptomatic acute cellular rejection, irrespective of the ISHLT EMB grade, R2R or 3R. That's a class 1 recommendation. Cytolytic immunosuppressive therapy with anti-thymocyte antibodies should be administered in addition to intravenous corticosteroids if hemodynamic compromise is present, and especially if there is no clinical improvement within 12 to 24 hours of intravenous corticosteroid administration, class 1. The heart transplant recipient with symptomatic acute cellular rejection should be hospitalized. Patients with hemodynamic compromise, such as hypotension, low cardiac output, or marked elevation of pulmonary capillary wedge pressure, should be treated in the ICU or an intermediate care unit with the ability to perform continuous hemodynamic monitoring and administer inotropes, class 1. IV inotropes and vasopressors should be used as necessary to maintain adequate cardiac output and systemic blood pressure until recovery of heart allograft function occurs, class 1. Antimicrobial prophylaxis against opportunistic infections should be administered when high-dose corticosteroids and/or cytolytic therapy are used for the treatment of rejection, class 1. Follow-up biopsy should be performed 2 to 4 weeks after initiation of therapy for acute cellular rejection unless there is a compelling indication for earlier histologic evaluation. That's a class 1 recommendation. This also represents a change from the 2010 guidelines, which said that endomyocardial biopsy should be performed 1 to 2 weeks after initiation of therapy for acute cellular rejection. How about the management of acute antibody-mediated rejection? When AMR is suspected, recipient serum should be evaluated for the presence, quantity, and specificity of anti-donor HLA antibodies. Serum samples should be drawn before initiation of therapy to avoid assay interference from the therapeutic agents, class 2A recommendation. The following treatments can be used to disrupt the immune-mediated injury of the heart allograft in AMR. 1 is high-dose IV steroids, 2 is cytolytic immunosuppressive therapy, 3 is rituximab, 4 is bortezomib or carfilzomib, and 5 is eculizumab. These are all part of a class 2A recommendation. Intensify the maintenance regimen, possibly including conversion of CIA to tacrolimus, or from azathioprine to mycophenolate mofetil, replacement of the azathioprine mycophenolate mofetil combo with the mTOR inhibitor, increasing target trough levels, and/or addition of a low-dose corticosteroid, and additional immunological monitoring is recommended. This is a very run-on sentence, but that's how the guidelines say it, class 2A recommendation. The following treatments may be used to remove circulating anti-HLA antibodies or decrease their reactivity. 1. Plasmapheresis, 2. Immune apheresis, and 3. IVIG. That's a class 2A recommendation. The following treatments are used to maintain adequate cardiac output and systemic blood pressure. 1. IV inotropes and vasopressors, 2. Mechanical support. That's class 2A. Follow-up endomyocardial biopsy should be performed 1 to 4 weeks after initiation of therapy and include immunohistochemistry evaluation, class 2A. Adjustment of maintenance immunosuppressive therapy may be considered. This can include the increase in a dose of current immunosuppressive agents and/or conversion to a different maintenance regimen, including conversion from CIA to tacrolimus, or from azathioprine to MMF, or mTOR or MMF to mTOR inhibitor, class 2A. Now let's hone in a bit more on CAV, chronic allograft vasculopathy. After the first post-op year, the leading cause of death in transplant patients is the development of coronary artery disease in the allograft. Chronic artery disease in transplant patients is pathologically distinct from typical atherosclerosis. There is intimal hyperplasia and smooth muscle proliferation, leading to progressive obliteration of the vessel lumen and loss of tertiary branching. That is why surveillance catheterization is performed frequently in patients after transplantation. How often should you perform this cath for post-transplant monitoring? According to the 2023 International Society for Heart and Lung Transplantation Guidelines for the Care of Heart Transplant Recipients, baseline IVUS in conjunction with coronary angiography at 4 to 6 weeks after heart transplant and at 1 year after heart transplant should be considered to exclude donor-transmitted or derived CAD and to detect rapidly progressive CAV and provide prognostic information. That's a Class 2A recommendation. OCT in conjunction with coronary angiography may be considered at 4 to 6 weeks and 1 year after heart transplantation to detect donor-transmitted or derived CAD and provide prognostic information. Class 2A. This is a new addition compared to the prior 2010 transplant guidelines. So the new addition is this OCT in addition to the IVUS for the 6-week and the 1 year heart transplant coronary angiography. Coronary CTA may be used as a non-invasive alternative to coronary angiography for detection of CAV in at least 2 mm size epicardial vessels. Higher resting heart rates in heart transplant patients may limit the quality of the study, Class 2A. What if you perform PCI in a post-transplant patient? Then what? Unlike in non-transplant patients where there is no requirement for relook unless the patient develops anginal symptoms again, follow-up coronary angiography is recommended at 6 months after PCI in a post-transplant patient for evaluation of in-center restenosis and progression of CAV, Class 1. The hallmark of CAV is concentric coronary intimal thickening affecting large epicardial vessels, intramuscular arteries, and the macrovascular bed. Non-transplant CAD usually has discrete eccentric lesions, whereas CAV is characterized by diffuse disease with concentric lesions, often affecting both epicardial vessels and microvascular. So it is quite difficult to PCI CAV pathology. If you have CAV, you may need to retransplant or do surgery, not PCI, because of the high rates of restenosis post-PCI. The 2023 heart transplant recipient guidelines say surgical revascularization in heart transplant patients with CAV is an option in highly selected patients who have lesions amenable to surgical revascularization. That is a Class 2B recommendation. The 2021 AHA-ACC SKY guideline for coronary artery vascularization says, in patients with cardiac allograft vasculopathy and severe proximal discrete coronary lesions, revascularization with PCI is reasonable, Class 2A. Now we'll just touch upon a few small things from malignancy, infection, and physiology. The most common fatal early malignancies post-heart transplant are lymphoproliferative diseases and lung cancer. The most common non-fatal and overall most common malignancy in heart transplant patients is skin cancer. Post-transplant lymphoproliferative disorders are associated with EBV, not CMV. Infection accounts for 20% of the deaths in the first year after transplant. Infections in the first post-op month tend to occur from nosocomial bacteria and fungi. Later transplant infections are more diverse, occurring from CMV, HSV, Candida, Pneumocystis jirovecii, nocardia, and Toxoplasma gondii. Because the transplanted heart is denervated, it lacks sympathetic and parasympathetic innervation, so resting heart rate is usually around 100 beats per minute. Heart rate depends on circulating epinephrine and norepinephrine. The transplanted heart has increased receptor density to epinephrine and norepinephrine. When a heart transplant patient exercises, at the onset of exercise, increased venous return leads to the transplanted heart to respond via the intrinsic Frank-Starling mechanism to augment cardiac output. Subsequently, circulating catecholamine levels, which rise as exercise, induce a delayed chronotropic response by the transplanted heart. This two-stage mechanism allows the capacity to support at least a moderate exercise in a large majority of long-term heart transplant survivors. Beta blockers may impair the heart rate response and should be used cautiously after heart transplant. By the first year after heart transplant, 90% of surviving patients report no functional limitations. The median survival after heart transplant is 13 years among those who are alive after the 1-year transplant. So we have now covered the post-transplant issues, immunosuppression, mechanisms of immunosuppression, rejection types, rejection management, CAV, which is cardiac allograft vasculopathy, malignancy, infection, and physiology.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.